These are all patients with suspected angina, remember. Here, the recommendation again, quite radical in many respects, was to go straight to angiography rather than push the patients through a series of tests which commonly wind up with angiography. And to summarize the guidance for the investigation of stable chest pain, patients were stratified by a level of risk, less than 10% up to greater than 90%. And in this low-risk group, the recommendation was no diagnostic testing and go on to rule out non-cardiac causes of chest pain. In the high-risk group, greater than 90%, optimal medical therapy, which of course, I'm not going to go into now, but that seems very important based on recent work. Plus or minus angiography if the patients don't respond adequately. And in the intermediate risk, as I say, in this, these people down here rule out with CT calcium scoring, which if positive, you go on to angiography, intermediate functional testing, SPECT, stress echo, or MRI, and here straight to coronary angiography. And one of the points that emerged from early publication of this guideline was people wanted to know, understandably, how this would affect the kind of patients going, how it would affect management strategies in patients, for example, going through chest pain clinics with suspected angina. And we were able to apply these criteria retrospectively to this large chest pain clinic cohort we put together, in fact to two cohorts, ours and one up in Newcastle, both of which came up with similar indicative frequencies for these various strategies of 29% of all patients attending chest pain clinics need nothing at this end, 14% need nothing at this end, 17% might go for calcium scoring plus or minus angiography, 18% for functional imaging, 22% straight to angiography. And I think this is probably the last slide I'm going to show. The key changes then in clinical practice that have been recommended in this guideline are, and these are the paragraph headings, do not use exercise ECG to diagnose or exclude stable angina for people without known coronary disease. For people with chest pain and a 10 to 29% probability of coronary disease, offer CT calcium scoring, and then there are recommendations depending on the score. If it's 0, reassure the patient, and then go for angiography if it's higher. And finally, for people with chest pain and quite a high probability of coronary disease, straight to angiography. And my final word is, you're not going to get it right every time with this strategy. Of course you're not. CT calcium scoring and angiography, as we've heard in previous talks, is not a perfect test. That you'll, in some patients, you'll get it wrong. The reason we came up with these recommendations is that you'll get it wrong less often applying this kind of strategy than we all currently get it wrong using the exercise ECG. Thank you.
Laura, ladies and gentlemen and colleagues, one of the advantages of speaking last is that all your talk has been given by the previous speakers, or at least a large chunk of it. So you'll be sad to know, Howard, that we're not going to go through Bayesian analysis with decision matrix theorem. We're not going to go back to the Reverend Bayes in any way, shape or form. We're not going to go back to the reason I suspect was the answer to the last question, which is why is sensitivity and specificity so good when you first do the tests? And the reason is you can get the results you want by choosing the populations that you study very carefully. So that the prime example was a wonderful study, which Duncan may well remember, on analysing patients who had aortic regurgitation and using gated blood pool studies to tell whether or not they'd actually come to the time when they needed their valves replacing. One study group all had pretty good going aortic regurgitation, and Geoffrey Borer, who was the main author at the time, chose a group of 18-year-old Mormons as the normal control group. Now, it wasn't very difficult to work out which group was going to be highly differentiated. It was very easy to do, and it's the same with any test. If you look back at exercise testing in the early 1970s after Bruce published the original data, you will find that the groups were very carefully chosen so that you had wonderful specificity and wonderful sensitivity, but the normals were clearly normal and the abnormals were clearly abnormal. And all you had to do was take a history or look at the patients coming through the door. You didn't need an exercise test to tell you what was going on. And it's from this point onwards that my worry about rapid access chest pain clinics has always been based. Duncan and I and many others in this room go back to the days of the mid-1970s when David Redwood, Simon Redwood's father, published in an editorial in Circulation, Wither the ST segment with Geoffrey Borer and Stephen Epstein. It was a very important paper because for the first time it said that you had to look at the probability of disease in the population you were studying in order to get some idea of what the meaning of the test that you were doing was the result. And it comes back to this question of if you get the same result in a 16-year-old girl and a 65-year-old heavy smoker, then the test itself is of no value at all. And so my fundamental objection to rapid access chest pain clinics was that we were always using less than perfect tests, which we've been using for a long time. Attempts to refine them had taken place over many years. Our present Tsar, Roger Boyle, you may remember the ST segment slopes in the early 1980s. Kim Fox presented papers at the Cardiac Society on 64 electrode positions on the chest X-ray. But all of the tests were fundamentally flawed. And in fact, it was Adam Timmis, whom I'm very grateful to, if he's still here, because it was Adam's two papers, the first of which was in 2007, when he actually said that how effective were rapid access chest pain clinics, and he has alluded to it already. But the crucial thing about it was that it was good at identifying patients in high-risk groups, but the patients diagnosed with non-cardiac chest pain accounted for nearly a third of the patients who ended up with heart attacks and major coronary complications. And they were the patients who were sent home, let alone the patients with a low test probability who were incorrectly identified by the exercise test as not having disease. And it was only a year later that Adam actually published an article in the BMJ which I think should have spelled out the death knell of conventional access chest pain clinics, when he said, as he's already alluded to, that the incremental prognostic value of the exercise ECG in the initial assessment of patients with suspected angina, his conclusion was that, unfortunately, most of the prognostic information could be derived from an adequate history and that the incremental prognostic value of the exercise test was of little value. And if you go back to the original paper by Darmond and Forrester in 1979, that's not Duncan, I'm afraid, it was a very, very important paper because what it said was that if you looked at all these non-invasive tests, you looked at stress echoes, you looked at thallium scans, all of them you could only interpret in the light of a clinical assessment of pre-test probability before assessing the post-test probability. And so all of these things come full circle in the end. And it was actually after an awards ceremony in Birmingham last year, in November, for the community cardiac scheme run by the Bexley PCT, where patients are actually seen in the community at the surgeries by a consultant cardiologist, and then it's decided as to what tests they should have, referral to the local hospital. And this study, this particular project has won numerous awards well before I was asked to help with it. But on that particular evening, we were sitting in the bar afterwards and discussing what we could do to try and have a new approach to some of the problems we were coming across in, clinical cardiology. And I knew that the Aquilion 1 scanner was coming online in December, and on the basis of 3 years of using 64-slice scanners for private patients, I was convinced of the value of the scanners. My number of invasive angiograms had dropped dramatically because of the use of CT, and I also felt a bit dubious, I have to say, about the use of EBCT scanning, because I was worried that you detect calcium, but they may not be the lesions which are the worrying ones, as Duncan has already alluded to. So anyway, with the help of the Chief Executive, who's here with us this evening, we pushed through a pilot study within 3 weeks. We got funding for CT scanning, and the next 2 slides are really just to show you the sort of format of what was happening. The GPs refer the patient into a rapid access chest pain clinic, except that it's based in the community. They don't have to traipse up to hospital, they don't have to pay car parking charges, and they quite like coming to the surgery because they have half an hour to see the cardiologist. And we give them 30 minutes and we take a proper history and we assess the pretest likelihood of disease. And clearly, if they've got unstable angina or if they've got chest pain or minimal exertion, then we're not going to faff around with any other tests, we're going to refer them straight to A&E. Now, if they've got clear non-cardiac pain, if you press on the costochondral joints and they jump off the table, then clearly you're not going to carry out any further tests at all, you're going to send them back to the GP. And you reassure the patient accordingly. However, if you're not sure whether they have angina or not, then the idea is that you go into the pilot study where we offer CT angiography using the Aquilium 1 scanner as a sort of public-private plan which has worked extremely well. We review the patient the following week with the results. If the test is normal, we can reassure the patient in a way that we've never been able to do before. Because as Duncan says, if you have a normal CT angiogram using this particular scanner, then they don't have coronary plaque disease. And you can say to them that there isn't a significant risk at the present time of any immediate problems. You can reassure them, and as I say, you can discharge them to their GP. Nothing appears to come up on that, but basically that says that you go on to CT scanning. If you've got coronary disease, then if it's critical, you refer them for further angiographic studies and appropriate treatment. And if they don't have critical disease and you think they have controllable angina, you can treat them appropriately. If they have persisting angina despite medical treatment, you then send them to the cath lab with, as Jonathan Hill was saying, structured testing, pressure wire studies to establish what the best form of treatment is. And again, if their angina is controlled on best medical treatment, then it's reasonable to continue with that treatment, addressing the risk factors aggressively and dealing with the situation appropriately. So that's the format. And we started in December, and perhaps I can come on to that in a moment. If we look at the data, and it is still being analysed, and so therefore this is only preliminary data, and for the sake of time I'm not going to go into it in great length. But in the first 3 months, I saw 77 patients in the local surgeries and discharged 32 patients to the GP if the symptoms were clearly not cardiac in origin. We've had no sequelae, there's been no comeback, nobody's pitched up with an infarct so far. 2 had clearly severe anginal symptoms provoked on minimal exertion, and because of my colleagues and their help at the tertiary centres, we were able to get them catheterised within 48 hours and appropriate treatment given. 1 went to surgery, 1 had angioplasty within a week. 43 had CT angiograms, and all the studies were diagnostic. And I think the important findings are these. Out of those 43 patients, only 1 has needed to go to bypass graft surgery for left main stem equivalent and right coronary disease detected on the scan. We had 1 patient whom we sent for pressure wire studies because after the 3rd consultation of describing exertional chest pain walking uphill with an osteal LED lesion, even though it didn't look significant on the CT, I felt that we needed a pressure wire study to see what was going on. You could equally well argue that stressed echo would have been reasonable or any functional study, but I felt that we needed to see, because of the question of the osteal disease, in fact, at subsequent testing, the pressure wire studies were negative, and the patient then came and told me he had a day's worth of chest pain and pointed to the costochondral joints, which was a bit frustrating. So we can all get it wrong. 3 patients in the first 30, and I think this is